Good morning, everybody. I'd like to welcome you to our workshop. Delighted to be joined by colleagues from two other academic health science networks, Joe and Adam, and also Vicky and Sarah, who support work in the National Quality Improvement Clinical Audit Network. We're going to be talking to you today in this workshop about how we might improve patient care through the adoption of medical technologies, with a focus on NICE recommended medical technologies, but also using some of the tools and techniques that we know many of you in the system utilise around clinical audit and quality improvement. I think we've got a mixed audience on the call today from across academic health science networks, people working in provider trusts and ICBs, and also I think we might be joined by some colleagues from NICE as well, which is great actually. Feels like we've got the sort of three main partners who work together in our quest to support better patient care through the adoption and implementation of proven medical technology. So my name's Stuart Monk. I'm a National Programme Director for the Academic Health Science Network. I'll pass over to Vicky.
Good morning, I'm Vicky Patel. I'm the Chair of the National Quality Improvement, including Clinical Audit Network, and the Clinical Effectiveness Manager at the Rotherham Foundation Trust.
And good morning, I'm Sarah Chesel. I'm the lead for the Dorset Innovation Hub.
Good morning, I'm Jo Murray. I'm the Associate Director for Innovation Adoption Strategic Programmes at Wessex Health Innovation Network, formerly known as Academic Health Science Networks.
Good morning, everybody. I'm Adam Smith. I'm a Project Manager and MedTech Funding Mandate Lead for Yorkshire and Humber Health Innovation, formerly Yorkshire and Humber AHSN.
We could move to the next slide, please, Annie.
Thanks, Stuart. So today in this workshop, we want to create an effective learning environment. So it's a plea from us to help support you. Please take the time just to put your phones to one side unless you're on call. Close Outlook. Don't be doing emails at the same time as we're having this workshop, and really to utilise the opportunity to participate. So we've got Q&A session at the end, and we've got opportunities for you to think about how you might take learning back to your organisation. Share your experience. You'll see that we've got various different ways you can do that. And please, there's a very brief evaluation in Teams at the end, so if you can let us know what you think about the workshop. Next slide, please. So today we invited you to join us to look at the context. So a brief overview of NQICAN and the Academic Health Science Network, and as Joe's alluded to, there's a very recent name change that Stuart will talk us through. Looking at the opportunities to collaborate and the improvement approaches. So really getting into the detail of the workshop of how we can improve patient care and outcomes by the approaches that we take. So looking at the evidence, right tool, right time, project management, some of the tools we use, and you've probably guessed it by the fact that we are joined by Vicky from the National Quality Improvement and Clinical Audit Network, NQICAN. We're going to be really looking at clinical audit as one of those main tools. We've got a facilitated session, so we're going to ask you some questions about what you feel are the key elements. I'm delighted that Joe and Adam will be facilitating those. And then at the end, we're going to be asking you about what you're going to take back to your organisation and what will you be doing. So as we work through the slides, or what will you be doing, I beg your pardon. As you work through the slides, as we are talking, we're interacting, please just think from your perspective, think, how would we do this in our organisation? How can we take forward elements? Just noting people are putting into the chat points about their role and what they'd like to get out of the session. So thank you, Stuart, for taking that forward. Next slide, please. Very briefly on objectives, I won't go through all of these, but I have just said that we're going to introduce clinical audit as one of the key tools that we can actually support implementation of NICE guidance approved technology, so MedTech Funding Mandate. And then next slide, please. And then that's over to you, Vicky.
Fantastic, brilliant. So I think if we just move to the next slide then, please. Lovely. So for those of you that are on the call who don't know much about NQICAN yet, a quick brief overview, and obviously an opportunity for those that do, it's just that recap. So we are We are a quality improvement including clinical network. We're made up of 11 regional networks around the country, all of which have got a fabulous regional network chair, maybe a co-chair, deputy chair and steering group to help lead each network. If you're not yet a member and you'd like to join, please do email the nqi.can1@nhs.net inbox and we'll put you in touch with your local chair. We've also got a network and sharing forum known as the NNSF where you can join and become a member. It's a platform for sharing and learning together to improve patient care. You can add topics for discussion yourself, respond to queries raised by others, share tools and resources. NQI CAN's also got a common purpose to support our local members to deliver those high quality projects that do help to improve patient care as part of our local programmes. And we do achieve this through our key drivers that are outlined here on the slide. So if we move to that next slide, you can see that our NQI CAN members, our ultimate aim is to improve patient outcomes. And our NQI CAN members and the wider quality improvement community, we're all involved with NICE guidance, whether it be as part of your local clinical audit programmes and wider quality improvement programmes, or implementing NICE guidance within your own organisations and across the system. We know within our networks we've got some early adopters of the MedTech Mandate, and we've also got members who are still to start and agree that process to consider that implementation. And we also know that as a network, we've all signed up to addressing those health inequalities. And the suite of the NICE recommended medical technologies, if implemented, can provide more equity and access for groups and individuals who may experience those poorer outcomes. So our closer collaboration with the AHSNs in that adoption and spread of proven innovation is really to further support our network members to share and learn together so that we do all move to that adoption and spread, but working with our own local organisations, systems and community to get this right based upon local need. So we will emphasise today the importance of measurement within that adoption and spread and how clinical audit can be an important QI tool to achieve this. NHS Impact provides us all with that continuous improvement framework, and collaborating with the AHSNs further demonstrates that improving patient care together. So I'll hand over to Stuart and he can provide some wider context through the lens of the AHSNs.
Great, thank you, Vicky. Little bit of complexity here, actually, as Joe and Adam have alluded to. We are going through a name-changing process at the moment. So many of you will know about us as the Academic Health Science Network. Our name is transitioning to being the Health Innovation Network. That started on Monday, and each of the regional AHSNs will become Health Innovation, for example, Southwest or Yorkshire and Humber. So that's happening now. So you'll see more of that. Our role does not change. This is still who we are and what we do at a very high level. Our mantra is to transform lives through healthcare innovation. And there's two ends to that. We support innovators to develop their innovations. And then we also at the other end support the spread and adoption of innovation at pace and scale across the system. We use this 4Cs analogy to describe how we do that. Basically, we catalyse innovation. We connect partners across sectors, and it's great to be talking here with colleagues like Vicky and Sarah who work in the system and that we work with quite closely to support adoption and spread activity. We create the conditions for change, so we do a lot of work on the cultural side with teams across the NHS to try to create better receptivity to innovation and spread and adoption. And as I've said already, we encourage the spread and adoption of innovation at pace and scale across the system. You can see on that map where we work in England. Sorry, Annie, go on. Now, I wanted to dock this workshop in the MedTech strategy. And interestingly, I saw a colleague introduce themselves as being formerly part of this team, which is great to have. The MedTech strategy was published in February by the Department of Health and Social Care. It's becoming a really important document in the context of our work and our world. There are lots of things that are coming from it. It sets out 3 high-level objectives for the right product in the right place at the right price, and it's got lots of priority areas listed about how different partners like us will work with industry, government and the health and care system to deliver on its objectives. I'll bring you back to some of what Vicky was saying actually in this point around equity of access to proven medical technologies. That's certainly a key driver for us. We want to see as many of our health and care settings adopting the things that are proven to work across England, so that as many patients as possible can benefit from different parts of our populations. And we work quite closely with colleagues at the Accelerated Access Collaborative and NICE to support the spread and adoption of technologies. One of the key vehicles that we've got that I'm sure many of you are familiar with is the MedTech Funding Mandate, which is an NHS England AAC policy that has 11 NICE recommended medical technologies on it currently. We're hoping to add more to that as the years go by, that we then as AHSN support systems to scale and implement in their setting. So that's a little bit of context from our side. If we can move to the next slide, please, Annie, we can talk a little bit more about collaboration, which again builds on what Vicky was saying and the opportunity here that we see through this workshop. National strategy and policy are placing increased emphasis on patient access to medical technologies, and you've seen that on the previous slide through Department of Health and Social Care's MedTech strategy. It's vital, therefore, that the work that we do in our network aligns with the work that National Quality Improvement and Clinical Audit Network and teams on the ground are already doing with their stakeholders. The regional team in NICE, for example, we can all work together to support rapid and effective implementation of proven medical technologies in a way that aligns not just with the national diktat, but also with local priorities and ways of working and that type of thing. So we see these workshops really as being like a first sort of toe in the water, really. You'll hear more examples from Adam and Vicky and from Joe and Sarah about some of those local examples of where partners are working together to support implementation of medical technology, coming at it from slightly different perspectives, but ultimately succeeding in enabling better patient access to the technologies that we support through the MedTech Funding Mandate in this example. And that visual there just shows you some of the key elements of collaboration that we believe to be really important in the way that we all work together. So hopefully you'll get that sense by the end of the workshop about how you might start to do that in your local systems. Come on to the next slide, please. I think I'll be passing back to you, Sarah.
Rookie error, muted. Thanks very much, Stuart. Really appreciate that. So just thinking about the context, if you can come to the next slide, please, Annie. Recognising that we've got a variety of folk in the room. Forgive me, I don't want to teach anyone to suck eggs, but we just want to talk about the context of where we're coming from with these medical technologies and implementation to improve patient care and outcomes. So that focus is on, as Stuart's already said, the MedTech Funding Mandate policy, looking to reduce inequality. As providers, so if we're in the acute trust, we are responsible, as are the commissioners, to take necessary actions to implement and make sure we've got the appropriate contracting arrangements in place. So in other words, at University Hospital Dorset, and I'll use that as the example, we've got a couple of local colleagues in this call. We're responsible for making sure we're reviewing the MedTech funding policy, but our commissioners, NHS Dorset, are also responsible for making sure they're taking necessary actions. And in Dorset, I work very closely with our commissioners to ensure that the funding is ring-fenced for appropriate activity. And that's important, how we get that actual strategic link with the commissioners. So using that as an example. So the MedTech Funding Mandate mandates that commissioners fund the technologies where clinically appropriate. So it's about the services that are being provided. So that's at that national level coming through. Delighted we've got NICE colleagues with us as well today. So MedTech Funding Mandate products are NICE approved, and the use of the word approved, published, means that we need to look at, as NICE states, that there's an expectation that eligible patients will have access to these MedTech Funding Mandate technologies. It, of course, is much more complicated than that, and we need to be mindful when we're looking at the NICE guidance, what NICE is actually saying. So we're going to use an example in a minute, Gammacore, which I'll come to in just a mo. but it's ensuring that you're aware what NICE is saying. So if NICE is saying that there are special governance arrangements in place, it means it can only be provided within this health and social care context under research conditions. So in other words, that additional consent is required. But in the majority, we're seeing that NICE are saying that they are supporting the evidence bases there and we should consider. So therefore, NICE is saying that adoption can be used to as evidence for the provider to meet its regulatory requirements. So it is one of the requirements as we look for example, some of the sequins, as we look for CQC. Then as providers, and if I continue to use University Hospitals Dorset as the example, the organisation has a responsibility to implement the NICE guidance in their local context. So if we're providing services to such patients, we should be considering NICE guidance. So it's considering it on behalf of the department rather than the individual clinician. And sometimes when we get clinician non-agreement, we need to make sure that that goes through the appropriate quality group and that our chief medical officer is aware. So it's appropriately, you've got that appropriate audit trail coming through. So that's those governance structures in place to monitor the introduction of and decision not to adopt new devices and procedures. And in addition, we need to provide that rationale. So NICE encourages us to say, are we in agreement with the NICE guidance? So there is that open communication with NICE so that we can actually say we're questioning evidence, or can we just clarify certain points? So we need to be really clear about that rationale. It needs to go clearly through and reported then up to our boards. Next slide, please. I should have said we're going to take questions at the end, so please do hold questions if there are any on those points. And obviously we've got NICE with us as well. So the example we're going to use as the threaded example today is Gammacore. I'm really delighted that we'll hear more about experience of implementation of Gammacore within the Yorkshire and Humber AHSN. So we're going to hear from Adam, but also we're welcome to hear from others that may have implemented Gammacore, and we have got that implemented in Dorset. Gammacore, the company is electrical, but Gammacore is a non-invasive vagus nerve stimulation. So it's a device that sits on the neck. It's self-administered by the person or the carer. And obviously it's got a conductive gel that is put against the neck, and it delivers an electric current for about 2 minutes. Currently, it's the only technology that uses non-invasive stimulation for the vagus nerve treatment of cluster headaches. So NICE doesn't approve cluster migraine, it's cluster headaches. Next slide, please. Thanks, Annie. And just thinking back about, and you'll see some more when I'm talking a little bit about project management, we need to understand what the benefits are so that we can look at implementation. So we very specifically use the benefits as listed by NICE. So I won't go through all of these. But for example, one thing to point out, bullet point 3, mixed levels of effectiveness reported. There is a 3-month free trial that enables patients to try the device. And a note that cluster headache significantly worsens day-to-day life. So the device has the potential to have life-changing effects. So it's thinking about those wider determinants of health. So cluster headaches can mean that folk can't work. So it's about how we can actually ensure that individuals, where they're able, are able to continue their daily activities, to be able to work, to be independent. But the important point here with this NICE guidance, this MedTech Funding Mandate, Gammacore, is that it should be offered in addition to standard treatment. So that is the prescription drug that is provided. And it hopes to reduce the amount of the drug that is taken and reduce the amount of cluster headaches. It is recognised that it is a small number of patients, but the impact is significant, and that's important as we think about implementation. And in Dorset, on the Poole Hospital site, we hold the clinic for headaches for the whole of Dorset, so it's showing it's a specialised clinic that's held, and that may be similar in other areas. I see we've got a colleague from Portsmouth here with us today, and also one from Ireland as well. So it's just thinking about the context about how are those services provided within your organisation or your areas. So next slide, please, and handing over to you, Adam.
Thank you, Sarah. So going off what Sarah's just gone through with the what NICE is saying around Gammacore, I just thought I'd share a bit of information around our implementation and adoption of spreader Gammacore in Yorkshire and Humber. So we can just go on to the next slide, please, Annie. Thank you. So again, Gammacore treats cluster headaches, which I'll go through again. Sarah's just covered, as well as the description. A few highlighted patient benefits that kind of relate to we were fortunate in our region in that we carried out a patient insight and experience project on behalf of NHS England and the AAC back in the summer, and we were able to speak with Gammacore patients, and a few quotes were taken from some of those interviews that we had. It really hit home, listening to the patients, that the impact that cluster headaches have on their quality of life, and the what Gammacore brings as to relieve those symptoms. A few there, not feeling pain. Not feeling pain was a brilliant feeling. It works. It's fabulous. A lot better than just having oxygen. And there were some quite harrowing quotes around what cluster headaches actually do to patients. We did a lot of work with Ouch UK, which is a charity for people who suffer from cluster headaches. Ouch UK refer to cluster headaches as suicide headaches, to reflect the mental state and that feeling that patients go through with these things. So we got that different insight, really, and we were really fortunate to get that. Another thing that came from it, which is covered in the NICE guidance, is that Gammacore, it doesn't work for everybody. It's not suitable for everybody. The clinical evidence given as part of that NICE guidance was that it should work in the clinical experience of in 25 to 50 patients. So it doesn't work for everybody, and our discussions with patients actually reflected that as well. It didn't have an effect for everyone, but fortunately for Yorkshire and Humber, as it said in implementation, our actual implementation of it, throughout that 2-year period where the AHSN supported the delivery, we had 128 new patients who entered onto the therapy, and of those, 87 went on to get further treatment. And we understand that by additional refills being authorised for those patients, so they carried on that treatment beyond that 3-month period that were referred to. So we managed to get we so far have had 67.9 patient response rate, which against that 25 to 50% that NICE, the panel experience deems, it seems like that's a, we've really we've kind of exceeded that so far. 321 refills have been supplied up to now, so that's another indication for us that once the patient's on therapy, they're responding well and they do so. And I've got a quote from the supplier who his reflection on Yorkshire and Humber was that it was a success. 67.9% response rate is pretty high, and as it says, it makes a positive difference to that area, and we saw that with the patients we spoke to as well. And I'm sure we're going to share the slides, so I've added a link to a video that's from Hull. Again, patient case study. We spoke with a patient on the impacts of Gammacore, and there's also some great reflection from the provider as well about what it's meant for their service. So when the slides are sent, I implore you to have a look over that. Thank you. Can I hand back, please?
Thanks, Adam. That was lovely to see the example from Yorkshire and Humber, and really interesting about the response rate. Really, that echoes the element of where NICE is saying it's, to be given in addition. So the opportunity is given in addition to the medication, recognising it doesn't work for everyone. Thank you. Next slide, please, Annie. So just thinking about the reason why we're here, we're just going to look really briefly at a bite-sized training about project management. Can I ask for a quick show of hands? Who has actually done project work or does project work? So if you can put electronic hands up, because I can't see everyone. Got 4, 5, 7, 8. Wow, we've got a room of people that are doing projects, which is fantastic. So forgive me, I don't want to teach anyone to suck eggs. We'll learn together, but I want to go through some points. These are bite-sized pieces taken from our Dorset Innovation Hub training. It's open nationally, so if you're interested in going to our full training, you are more than welcome. Just pop me an email. But from the perspective of this workshop, it's really thinking about, okay, what are we talking about here? And we're talking about MedTech funding mandates, which are innovations. These are, and we've got the term here, new adoption of new ways of working. So implementing something that's worked elsewhere. And you can see that on the last paragraph of this slide. And that's thinking about what do we mean by adoption and what's worked elsewhere. We're not talking about inventive innovation, so creating new ideas and products. We're talking about something that's got evidence base. So nationally, NICE has published guidance on, our threaded example is Gammacore, and said we should be offering this in addition to drug treatment. This is of benefit to our patients in this context. And for Gammacore, as we've said, it's just headaches. It is not approved for the migraines. So defining innovation is really important from the perspective of understanding what we're doing. And this definition comes from, as Stuart said, we work very closely with the Accelerated Access Collaborative, as well as NHS England Care Quality Commission. And this is a quote from their paper in February 2021. We can get that link for you if that's helpful. Next slide, please. So just considering, I'm going to presume as project managers, as folk that do projects, you're thinking about from the back of this workshop, how do I implement one of these MedTech funding mandate products? And there's several, and perhaps we can put the link in the chat to the different products, Stuart or Annie, if that's possible. But thinking about what we're trying to do. So if we're implementing an innovation, it's thinking within provider organisations, what are we trying to do? And if you don't work within a provider organisation, you're a commissioner or work within the AHSN or wider, this is an understanding of what we need to go through within provider organisations to get the appropriate approvals. And the first really is to highlight to you the Health Research Authority, the HRA table of defining different projects. So I've got a little snip of it here. It's a much bigger document, but the link will be on the slides when we share those for you. But thinking about what is it you're trying to do, and MedTech funding mandates fall within the third column, so service development, improvement and development. Thanks, Stuart. And it's thinking about, okay, what approvals do I need in place? What is it I'm trying to do? So I've just put on there the link as well about just double checking is the project that you're doing research. So you've got the HRA decision tool there. And then Stuart's put into the chat for you from the Dorset Innovation Hub site our frequently asked questions. And you can see some links in there, but perhaps have a look at that later on. So thinking about the context of your organisation and wanting to identify the project you want to implement, you need to understand what it is. We've said this is an innovation. You need to think about if you're part of the project team or you're the SRO, the Senior Responsible Officer, where do you need to register that project? And it's different for every organisation. So we've got a catch-all here. So it could be the clinical audit department, the research department. the innovation department, quality improvement department, transformation, or the project management office. It may be, as I discovered in some discussions last week, that if you're within the council, so within the local authorities, you need to go to the responsible officer. And it's about making sure you've got the right registration and approval for implementing this project. So we're implementing something new that will be used with patients. So it's about safeguarding, making sure we're really getting our ducks in a row. Next slide, please. Thanks, Annie. So as I say, this is very bite-sized, brief overview extractions from our Fundamentals of Innovation Adoption training. So it's thinking about coming from the perspective of understanding, also about the right approach, people, tools, and time. So I like to think of a golden thread between research, innovation, improvement, and clinical audit. And you'll see that we're using clinical audit as that real thread coming through to research. Looks at, is it better to treat with drug X or Y? We do the real world evaluations. We pop out in real world evaluations to innovation. We've got that nice evidence base that says, you know, we should be utilizing this for certain patients. And we look at then the implementation of that, so through improvement. And then we look at, once we're implementing, actually, how do we measure that we're doing the right thing in the right way to the right patients? So we look at clinical audit, and Vicky's going to run through that in just a little bit. Need to recognise that there are multiple tools that are used and multiple approaches, and it's really about making sure we've got the right approach involving the right people, so stakeholders, and using the right tools to get the best success and outcomes for your project. I'm going to recommend in a minute a few tools that we recommend within Dorset. Those are advocated as well by NQICAN. I've just double checked that with Vicky. But just stepping back one for a minute, it's also about understanding what approaches your organisation uses. So do you use QSA, Quality Service Improvement and Redesign? Do they prefer Lean, Six Sigma? So really understanding, what does your PMO office use? What does your QI team use? What does your innovation team use? Because you don't want to jar with the processes within your organisation. We need that seamless thread throughout so you can get the best from your project. So know and use these tools, use them as your toolkit. So just, if one thing I can ask you to take away from today, it's please find out what tools you could be using if you don't know them already. And if you've got a mo, please just pop that in the chat, what tools you're using. Next slide, please. Thank you, Annie. Some of the recommendations then, this is very, very brief, just highlighting some to you. So an older one is the change model. You can see it's the jigsaw on the right hand side. So our shared purpose, really worth having a look at. It is older, but is still very relevant. The main one that we use for our training is the leading the spread and adoption of innovation and improvement. Again, NHS England, and you can see that from the wheel there. NHS Impact, as Vicky's talked about, please get to know about NHS Impact. There is one NHS England approved improvement approach, and we're all understanding how NHS England will want us to take that forward. What's your organisation doing? Are you using QSA? Are you using Virginia Mason? Just have a look at and understand what you're using within your organisation. NHS Horizons, so the School for Change Agents. If you haven't been before, it's a blatant plug for Catherine Pereira, Helen Bevan. They have got their new, it's run every year, but their new course starts on the 13th of November. Just Google it, look on socials, you'll see it there. Starts 13th of November and is fantastic, absolutely fantastic. It's 5 or 6 weeks, 2 hours a week, free within that 5-6 week period. You can see on the bottom right there, Healthcare Quality Improvement Partnership. They are the commissioners of the national audits, and they've got their best practice in clinical audit. Vicky will be talking a little bit more about the work there with clinical audit. And then, as I've mentioned, QSA, so quality service improvement and redesign, and just being aware that QSA's now moved out of what was NHS Improvement, NHS England, to Aqua. So please just make sure you're up to date with the latest links for QSA. And then one that I haven't got on the list, but I've got the logo, is Plot the Dots. So Sam Riley and the amazing team making data count, and that's a tool that we really advocate. Next slide, please. Thanks, Annie. So just pausing for a minute, thinking about project management, thinking about what tools you're using, thinking about implementation of MedTech Funding Mandate and what we've said about how NICE have published this guidance, Gammacore for the threaded example we're using. When we're thinking about project management, it's really thinking about, at the beginning, folk can sometimes get really excited about something that's shiny, a new bit of kit. Wow, this is going to make amazing improvements. But it's thinking right at the beginning about the benefits, not the innovation. So it's bringing it right back to the focus of why we are in health and social care. So thinking about the benefits for our patients or service users if we're in social care. And then thinking about, and it can be quite provocative, this comes from NHS England, the spread and adoption, the 7 interconnected principles, and again, really worth having a read. It's thinking about the focus on the why rather than the what. So why would we do this? So thinking about the benefits for patients and service users, but also thinking about that pull, so that system focus. We really need this for our patients. As you've just heard, Adam was talking about, people being in really serious states of distress and it impacting day-to-day activities and being incredibly debilitating, and someone quoting considering to take their life. There's a real pull there to hear from our service users, our patients, to make sure we are taking forward really important innovations and implementing those. So taking forward priorities that pull. Sometimes when we push, we talk in Dorset about it, pushing against a closed door. If you're pushing saying you need to implement this, something's not quite right. So it's thinking about, why is there a push? Is there clinician non-agreement? Is there a misunderstanding about the guidance? Is there a lack of awareness and knowledge? And our workshop too really looks at that. So we'll look at that threaded example coming through in more detail. So it really means about explaining the benefits to patients, staff and carers, and actually understanding that in the system and with those that are adopting it, so clinical and operational teams. Next slide, please. So good project management, key points for consideration. We spend several hours on points like this, so it's really just key points of consideration, and happy for people to email me. So think about the funding, thinking about what type of project you're doing. Is it a pilot? Is it full implementation? And do you have the funding for that? So some bits of kit could be 30,000 as a one-off. It might be offered for a free trial, but what are then the ongoing costs? So the costs of the kit, as Adam was talking about for Gammacore. Thinking about the organisational approval, as I've already mentioned, and thinking about the business case. So you should have a business case in place to actually say the case of need, so that pull, and understanding the health economics behind it. So what are the benefits? How will this reduce readmissions? How will it reduce the use of an expensive drug, for example? So thinking about benefits realisation. Think about your project initiation document, so your PID, and within that, again, that case for change that you see within the business case, thinking about the scope, so what's within scope and exactly what type of patients you're looking at, not migraine, for example, and thinking about the setting. So if you're doing a pilot, is it within one ward, or as Gammacore, for the example I said, that we run the clinic within Dorset, and I'm delighted that we're using Gammacore actively in Dorset. What are the other dependencies? So thinking about, are you changing processes? What are the risks and the system drivers, and thinking about that priority? And as part of that good project management, thinking about the implementation and evaluation plan from the get-go. So at the start, you're thinking about the benefits realisation. So what's the baseline now? So what are the readmission rates, etc. for cluster headaches? And thinking about then when you've made that change, how you measure that. And we'll hear a little bit more from Vicky about that through evidence-based criterion and standards through clinical audit. Next slide, please. Scooting through, again, thinking about your SRO, your sponsorship for the project, so your senior responsible officer, your leadership and oversight, so regular project meetings, and thinking about the governance, so the regular reporting. Getting the right people in, so thinking about the key stakeholders and anyone that is impacted on by any activities you're doing. And there's a great tool in CUSA, which is thinking about stakeholders and mapping. So again, perhaps we could, I don't know, I can see that Sandra's on the call. Sandra, would you mind putting the CUSA stakeholder guidance in the chat if you don't mind? I can see a nod. Thanks, Sandra. Thinking about the appetite for change. So again, we'll talk about this more in our second workshop, and understanding those that want to adopt versus those that are actually saying, no, this isn't right. Think about the project's team's capability. So do you have the right skills and capacity, so time? And then governance, thinking about the necessary approvals. And I can't emphasize this enough. We must get our organisation's approval for implementation. So thinking about that through not only clinical audit, but through research, through innovation. If you don't know who to link in with, go to your information governance team. Your chief information officer will be able to guide you, and you need to complete your data protection impact assessment form. Don't forget your MD1. So these are medical devices. You need to make sure your organisation has approved use of this new medical device with patients. So slightly behind time, Vicky, handing over to you.
Not a problem, Sarah. I'm just realising we are giving an awful lot of information here, aren't we? And if you haven't yet looked at adopting and implementing some of these medtechs, it might feel slightly overwhelming, but please don't feel overwhelmed. Keep coming with us on today's journey, because we will make the slide pack available, the links, tools, and make it more, it'll be a resource that you can keep coming back to and visit. And obviously within the NQI-CAN regional networks, at the open meetings, in the forum, we can be having these discussions. We can keep these discussions going so that we're actually supporting each other to make sure we're considering this adoption and this implementation. So I just thought I'd add that in there, because obviously we're throwing in quite a bit into this arena for consideration. So I'm going to talk to you a little bit about clinical audit. So having decided then that clinical audit actually is that right tool to use in this context, you now need to prepare that project framework for your clinical audit, answering the why, the when, the what and the how. And we will explore that a little bit more as we go through these slides. So the innovative approach then to adopting this medtech sees us changing the way that we are actually treating patients with cluster headaches, as Sarah's already explained, but also how we can then utilise clinical audit as the quality improvement tool to ensure that we are getting this right. We can evidence that we've adopted this effectively and that we are following the NICE recommendations in practice. And then where we identify that maybe we're not achieving compliance for everyone all of the time, we look to agree those improvement actions. And then obviously identify further metrics of measurement to demonstrate that impact of any change. And that might be through repeated cycles or continuous measurement, but moving to that continuous improvement approach, which NHS Impact supports, which Sarah touched on. So to ensure equitable outcomes, the design and implementation of technology needs to respect ethical principles and local values. Decisions on the use of new technology should be made by the local users, and that implementation needs that long-term commitment and local ownership, which I know Sarah touched on. A commitment to measurement, however, is part of this process. So clinical audits should inform the local decision making, but as we've already mentioned, it needs to be planned alongside the adoption. So clinical audit outcomes should not be reviewed in isolation, but triangulated with all of the data sources and information, so it provides that context, that understanding, that variation. But you need to think now about the metrics, the data sources, the wider information that you need to identify in the planning stages of adoption and measurement. So how will you know that adopting this medtech, say, is going to make a difference? Having that expected impact on improving access and equity, resulting in improved outcomes. We want to know we're using this medtech safely, effectively, and that the patient is reporting that good experience. So the where, the how, and when do we measure to assure on those quality domains, and not forgetting now, obviously, that equity and access have now been added into the quality domains, and we need to be able to identify where we need to improve further. So just moving back to the why, what, when, and how, then we know why we need to measure to see how effective the medtech is being used to improve equity and outcomes. So the what is where your criteria and standards come in. So if we just move to this next slide, you'll see that we've got some here that we prepared earlier. So this is taken from the MedTech Guidance 46, obviously. You'll see here that we've got 6 criteria here, but obviously if you review the guidance, you'll need to measure more. But obviously for the purpose of today, we're just showing you these first 6. You'll need the local agreement here with your stakeholders in your organisation on exactly where your focus is going to be for the measurement. And as Sarah said already, involving those stakeholders from the start is really essential. Each criterion has been broken down, obviously, into specific and measurable standards. And the reason we do this so specifically is so that it's clear through your measurement where you might not be meeting any particular criterion. So it's specific and it's measurable. However, you still need to be careful that all your stakeholders agree how each standard is being interpreted. You can see here in the definition column in the table, for example, what could be seen as symptoms could be suggestive. So you'd need discussion and agreement before any measurement commences. With clinical audit, we're measuring against evidence-based standards, so you can each one's aligned to the standards within MTG 46 just for reference, and that is best practice of how we always lay out criteria and standards for clinical audit. Now, the final column here is where you'll identify where you'll get your data from to measure each standard, hence why you need to start planning at the start of adopting the medtech. If there's no current obvious data source to measure, you need to build this in, and we'll touch on this as we move through to the next slides and the stages of clinical audit. So if we just move to the next slide, we can't probably emphasize enough that this is a commitment to adoption, which does include effective measurement to inform improvement decisions and to assure on improvement outcomes. So you need to carefully consider what you need to know to assess if the adoption of a medtech has actually improved equity in terms of access and outcomes. What data do you need to either pull from existing data sets, or if it doesn't already exist, put measures in place so that you can access that information? So just thinking about focus and detail here then, agree the criteria and standards to measure and identify the data sources where you can access the information to assess compliance against those standards. Now you need to stretch yourself slightly further and think about that triangulation then with wider relevant information in your organisation that will further inform understanding and decision making. It adds that context to what the data is telling you. So for example, are you aware of what your local inequalities are in terms of access to headache services? You'll need to understand that when you're reviewing your data. Which groups, say, might already experience worse outcomes? It might be by age, by gender, ethnicity, disability, socio-economic groups. Have you had a recent GIRFT report? Have resources already been identified as an issue in providing an effective headache service? What's already been implemented in terms of wider recommendations to improve outcomes relevant to say this medtech? Will you be making changes, say, to improve access by who can refer into headache services, specialist nurses undertaking follow-up and review? What data and metrics are already being collected maybe by these individuals along the pathway that you can then access to measure the audit standards, or further triangulate with your audit data to review and understand the effectiveness of adopting this MedTech. So it's understanding right at the start what it is that you need to pull on to be able to measure the true impact of adopting and implementing. And don't forget, this might be across your system, it might be with partner organisations, depending on how your headache services are set up locally for you. So further thought and consideration then at this stage to embedding that measurement in as a continuous and, where possible, electronic measure of data, so it eases that data burden. For anybody that uses Power BI, it could be utilised to provide that analysis, releasing that time for the actual review and understanding and taking action on that data. Taking some time in the planning stages to really understand how you'll test your audit measurement, addressing any of those validity and reliability concerns before you start. And we'll touch on a little bit more of that as we move through, obviously. But final thoughts on measurement around, obviously, who's analysing, interpreting, translating that data for the right audience, and that audience will include your decision makers. So if we just move on to the next slide then and just think about that implementing change aspect. I've already mentioned the importance of that triangulation. So you agreed at the start what information you need to pull on for that wider triangulation to inform that understanding and that context. And you should also have agreed the right forums with the right roles at the right level in your organisation to review the data and information. Now, these roles may at this point bring more knowledge to that table, such as, have there been any recent incidents, complaints, other concerns, etc. Hence why you need to agree stakeholders at the start. Get the right people around that table. Forums, where are the most appropriate forums in your organisation, and at what point in the process do you need to be discussing data? Think about your clinical experts, your clinical leaders, your execs that are really going to be making those decisions. They've got the autonomy and the power to make those decisions. Don't forget to align with your wider improvement programmes. Don't duplicate but complement. Will any agreed actions from this audit impact on wider improvement that's going on within your organisation, or particularly along this patient pathway? Triangulation is really important. If we move on to making any improvements, who's leading on these? Who's leading on the action? How, where and when will we progress these improvements, and how we're going to monitor them? And then embedding this measurement as business as usual, but not just in the data collection, but who reviews it and where are we providing assurance to the organisation, and that we are showing that we're continuously monitoring and improving where appropriate. So if you've managed to embed an electronic system for collecting the metrics, you'll know that at any point your data's there for you to extract, review, understand your current position, help use that to help drive improvements, but also provide that assurance back to your organisation as well. So if we just move on to the next slide, you'll see us come back to criteria and standards. And it's just really to bring your minds back around to thinking about where will you now identify your data sources. So it's the final column here in this table. So in terms of planning for that measurement, it must be considered right at the start of agreeing that adoption. Then timescales mapped into your overall adoption plan, leading into the evaluation of business as usual for this MedTech. It's adopted and we can really evidence that we've got some improved outcomes. So if we move on to the next slide, we just really need to be thinking about now measuring for sustainability. So in order to be able to demonstrate the impact has shown improved outcomes, and not just at any point in time, we've got to show that we are measuring and monitoring continuously. So we talk about repeat cycles, we talk about re-audit, re-measurement. It doesn't matter if you start to measure continually from first use through to current date, or if you undertake a round of audit and then a repeat audit, provided that your methodology is measuring and reviewing that data over time, that continuous measurement to show and understand that variation. And you must have considered this measurement right from the start, as we've said, so the data is available and you can measure it throughout. And that last column in that criteria standards table, what data and information that you're going to need to be able to measure the impact, is vitally important. That data and that information is going to be your justification to continue as in terms of business as usual, embedding this into practice as fully adopted. Now, your organisation's process, which Sarah touched on, for introducing these safely and effectively, it might start with a trial. It depends what your process is locally. It might start with a trial, and then to review that impact, to fully approve and to continue as business as usual. So you must be able to evidence the efficiencies alongside improved outcomes and experience of the patient as well. And that, I know you touched on it, Sarah, is also thinking about capacity, capability, money, performance, resource, equipment, all those domains of quality. Utilise your benefits realisation tools and frameworks here, as this is exactly what we're setting out to achieve. It's not just about the here and now, but this is about adopting technologies so that we're future-proofing that health and care as we move into the future. That's the true definition of sustainability. We've got the 4 stages of clinical audit slide up here. I know, Sarah, you've touched on and mentioned HQIP, the Healthcare Quality Improvement Partnership. For anybody that's joined us that isn't familiar with clinical audit, head on over to either the NQICOM website or over to HQIP. There's an e-learning module on there, lots of resources, lots of guides. But this model that we've got here is taken from the principles of best practice for clinical audit. And I think any audit teams that are on the call today will say that we follow this approach within our organisations. So I think that's pretty much my slides, and we are going to move to a break at this point before we come back for discussions, but we're literally about 3 minutes ahead of schedule. So Stuart, I don't know whether you're happy to move to coffee or whether you want to provide the opportunity for any questions at this point.
I think it might be worth taking a couple of questions actually before we go and forget. So I mean, first of all, Sarah, Vicky, and Adam in the midst of that as well, thank you so much for bringing clinical audit, project management, implementation to life. I mean, one of my reflections would be that the principles that you set out and the tools that you've described are so important to think about when we're implementing innovation, and I'm not sure that we always do, to be absolutely honest. And I think that if you're going to sustain adoption in a way that's useful to both patients and the workforce and the service, it feels really important that certainly on our side in the AHSN network, we are working with teams in the system to use these tools in the way that they probably already do, but with that implementation of innovation slant on.
I think, if I may, Stuart, really quickly, I think it's fascinating. We all know project management and we kind of crack on with it. We're doing so many different projects, but actually just going back to the basics and looking at the priorities, doing a smaller number of projects, doing them well, really supports with that implementation and the impact, the sustainability, benefiting our patients. So it's kind of getting ourselves into a different mindset and keep thinking, right, let's go back to the basics. Let's just really look at what are we trying to do here. So we're running hot. We've been running hot for years. So it's that step back and just really try and get it right.
Thanks,
I think
Sarah.
so. It is that commitment of your organisation, isn't it? So it's like I said, if you're not already going to collect the data whilst you're adopting and implementing it, you know that you will have to make sure that you do your methodology to collect over time. But it might be that you see it go onto your formal clinical audit programme for the following year for ones that you've adopted. And again, if your clinical audit department isn't the department that implements nice guidance, it's about working together to make sure that you are joining up to collaboratively make sure that you're implementing, adopting, and you're measuring alongside it.
Thanks, Sarah. Thanks, Vicky. There's a couple of themes that I think we can explore for a few minutes, and then I suggest that we try to break at about 11:05 and we'll come back at 11:15 if that works. But let's just take a bit of time to reflect on a couple of things that have been posted in the chat, actually. First one, Sandra, you asked an excellent question that a few of us have contributed an answer to, but how do you create pull rather than making this all about push? I think it's a great theme to explore. From our side in the network, we've, as you've sort of got from myself, Adam, and Guy's responses, there's different ways that you can think about it. certainly from my own experience, it's always worth just taking the time to understand the context that you're about to go into, the people, the team, the organisation, what their priorities are, what are they already working on, that the medical technology that you're working on the MTFM could align with somehow. There's a national piece to that too, as I think Adam's posted into the chat. What are the national strategies, things like elective recovery, winter pressures, you know, all of that big stuff that we know exists. What does the MedTech align with in that sort of national bracket that might still resonate with a local system because they're probably already working on it? I think all of that's really important. And you have to build will in people. We talk about will building a lot. This is about people, and those teams and people that you're working with need to want to do the implementation of the technology. And how you do that, I think, is quite important through storytelling, through evidence, you know, all of those things combined to can gradually sort of sway somebody and get somebody on board. So the softer side of change actually probably takes us more into what we're hoping to deliver in the next workshop come the spring, but nonetheless important to be thinking about now. Sarah or Vicky, have you got any reflections on pull, creating pull?
Yeah, I'm just thinking about that whole triangulation theme again, and we talk about triangulation once you've got data in your hands, but if you're working within a provider organisation, and I know you've just touched on almost the getting back on track, Stuart, that a number of us are still obviously trying to achieve. Think about that wider triangulation to make sure that you are linking in with the different roles in your organisation. I'm just thinking about in your specialties, your care groups, directorates, divisions, whatever you call them. You'll have your ops director or your general manager, you'll have your head of nursing, you'll have your clinical director, and they're constantly looking at all the domains of quality and alongside performance. So it's almost having somebody to champion these med techs, isn't it? So you've just got, and it might be you working in the clinical effectiveness department that's constantly saying, have you considered this technology? Because actually, although it's a bit of return on investment to begin with, it is going to help us cut down on waiting times. It is going to improve equity and access. It is going to improve those outcomes. And it might be that adopting a piece of technology means that you can carry out a procedure as a day case and prevent overnight stays. So little bit of investment to begin with is going to save on resource and improve outcomes further down the line. So it's just trying to think slightly differently, making sure you're part of those conversations, looking at quality as a whole, and yeah, be that little voice chirping away. Think about this. Could we adopt this?
And if I may, Stuart, a reflection, and Vicky, I absolutely totally agree with you. I think that's a fantastic outline. A reflection for me from a slightly different angle. So with my project management head on, looking at, you know, the pull, the priorities, both locally and nationally, which obviously, you know, for our ICS, the local priorities and the national priorities feed in. There is still only so much capacity and capability in the system. So we're complex organisations within a complex system. So multiple organisations in Dorset, all complex systems. And it's actually understanding the context of where individual organisations may be. So with one of our MedTech Funding Mandate we are implementing, it's understanding that there is that pull, there is the desire. We have the champion, as Joe's put in the chat. But actually we need to understand the steps to implement. And with this particular one, there is a bottleneck with informatics. So there's hardware that requires to be put in. The informatics team and whatever organisation you're in are hard pushed because of all the digital creation, hardware, software. And it's understanding where in your project you are so you can report back that we are implementing, we are in a queue, this will be implemented by. So really being able to rationalise that as well, because it's not, oh, this is a great thing to do, we've got to do it. And then, you know, 2-3 months later, we're implemented. This is about a true project and seeing through to that benefit realisation.
Again, really helpful both, and I think this is so important for us working in the network. This is our day job, supporting the spread and adoption of innovation, and I think we don't take the time to deliver workshops like this enough with people like you both and others working in the system to understand your worlds in a bit more depth. So yeah, thank you both again for being here talking with us. It's great. Before There is another question. I think we'll go and have a break now, and then we'll come back to that a bit later. Alexandra's posted a question, which is a good one, around the timelines resulting around Gammacore. So maybe Adam, you can have a think about that one, and we can come back after the break and quickly pick that one off. We are going to go to breakouts now. We're going to split you into two groups. This is the point where we really want some of your insights and feedback, actually, and hopefully you'll find it interesting from a learning perspective as well. Everyone's reappeared. Lots of people with cameras on, which is great. Let's go to some feedback from each room. We'll start with the room that I was in, actually. Adam, would you like to go first, and then we'll come to Joe?
Yeah, no problem. So kind of the top of the list, really, that were fed back with the stakeholder engagement element that's needed in order to successfully implement the MedTechs. So there needs to be that appetite for implementation. Key people need to be involved, and those key people need to bring some kind of influence or enable this activity to happen. But as well as key people, there also needs to be that understanding that these individuals make up a whole, so it has to be a system buy-in. You can have certain individuals that might be influential and might be able to take it so far, but without others being part of that, you could come up against barriers and not be able to progress. I think there was a great comment around the environment and appetite for change, kind of addressing the headspace to implement innovation. Sorry, so we're putting a lot of change elements onto the system, and they need to be in a position where they can contribute and work to that. There was an element around the MedTech Funding Mandate and the mandation word. It brings quite a lot of negative connotations in terms of what we're trying to do, in terms of responses. Providers feel like they need to do it. Commissioners feel like they need to fund it, and there's a need to really sensitively navigate around that as well, and open that dialogue. And yeah, that's we as AHSNs can speak quite widely to that. There's been a few hostile rooms for that, just purely for the title of what the MedTech Funding Mandate is. Yeah, so I think they were the main points. I don't know if anybody picked up on any more.
Just the point that innovation shouldn't be an add-on; it's an improvement tool, so not seeing it as an extra. And then the other one that we work with the clinical and operational teams to implement, and that has the best opportunity to embed something substantially, so rather than a team helicoptering in.
Yeah, great. Thank you, Sarah.
Fabulous. Thanks, Adam. Thanks, Sarah. It was a really rich discussion, covered lots of ground. I think the language around this is really interesting, that the use of the word mandate in the MedTech Funding Mandate. I think that gets people's attention, which can be helpful, whether that attention is negative or positive from the outset. I think that ultimately can still prove to be quite helpful. And then around the NICE guidance, like the, NICE recommend the use of these technologies. That's the word that they choose to use, and that's an interesting word, isn't it? It's not a mandate, but it is a formal recommendation that people should use something. And again, I think that's quite challenging for us all to get our heads around at times, to be honest. But thank you, Adam and Sarah. Great summary. Joe, do you want to come in and talk about the group that you were facilitating?
Yeah, thanks, Stuart. So we had a bit of a different conversation, I think. So we started off with an example of a small organisation where perhaps it was harder to realise the savings. So when you've only got a small number of patients that a particular tech might be relevant to, it doesn't actually result in the savings. It might do over a very long period of time, but it's not cash releasing. So with hindsight, perhaps there wasn't that kind of immediate cash saving expectation. So a bit of a rethink about, okay, maybe some of the cheaper stuff we can do a green light, the more expensive stuff we need to have a lot more sort of senior oversight and to really think through, is this going to work for us as a smaller organisation? And we talked about how clinical buy-in was important, but is not the be all and end all. You do have to engage your finance people, you do have to engage all your other stakeholders. So I think several of us will have had experience of that, where you've got a clinician that's really keen, but in terms of working that through, and then the complexity of working out which finance stream it comes out of, whether it's capital or not, how do you unlock that funding? We also talked about the variation of how ICBs are working with this. Some have devolved the money to the trust and said, crack on, up to you to sort it out. Others have, for example, in Dorset, they've been very good at backing and ring fencing the funding, and they've got a method of retrospective reimbursement, which is great. So again, just recognising that there are going to be different approaches, and that can be hard, but the benefit again of us as a network is to share that there is another way and to try and influence and feed that in. We also talked about the need to have senior management and senior clinical management to get the oversight and awareness of the products, and the sort of almost the requirement to deliver these, and recognising that they have multiple competing priorities. So how do you keep it high on their agenda? That this is an important thing to deliver. And then a final point that came not from the AHSNs but from Vicky, thank you, about how the AHSNs can support you with writing the business cases and provide you with that evidence of the money saving over several years, etc. So thank you for that, Vicky.
Thanks, Joe. Another rich conversation by the sounds of it. Really good. Lots of different themes explored, some commonality with the first group, especially around stakeholders. I like the sound of the conversation that you were having around resource saving and the sort of financial complexities around some of this, and how different systems interpret the resource savings that are set out in the NICE models, and what that means and doesn't mean in terms of being non-cash releasing, but still a resource saving. I know that can result in a lot of complexity and discussion with clinical teams, and probably more so with operational teams as well when it comes to implementing these. Really good. Look, for everybody that contributed to those discussions and is here, we will theme them and we will share a kind of sort of potted summary of them in the along with the slides that accompany this, so you can see a bit more as to what was discussed, and actually that will inform what we then go on to discuss with you in the second workshop next year as well. So thank you all for contributing to that. Really valuable insights that we've gathered. We're going to move now to sort of a broader consideration of the some of the key themes that have been explored during the workshop. Vicky, I think you're going to lead us through this one.
I am. It was a bit of we really want to know from you what you're going to take back to your own organisation, really. I know we've probably given you quite a lot of information in the last hour and a half, and you almost need to go away and reflect on that to really be thinking about where your current position is and what you need to do next. But we're intrigued already to know at this point in time what you'll take back to your organisation. So the best way to do this is for you to start reflecting and start typing into the chat. And obviously, as people are starting to put things, we'll have a little bit of a discussion as we go. But yeah, it's a pledge, really. You've obviously committed to spend this morning with us to try and look at how we can all work together to adopt and implement these technologies. So it's okay, now you've spent this time with us and we've been discussing it all. What will you pledge to now take back to your own organisation? And whilst you're doing that, I was just reflecting on what you were saying, Stuart, in terms of the fact that both Sarah and I today are coming obviously from different perspectives. Sarah from within the Innovation Hub, myself from within a provider organisation, and I've recently moved organisations, but still in South Yorkshire, so still working very closely with Adam. And I know in my previous organisation we set up quite a robust process early on And we had a group of us around the table, which was clinical effectiveness. It was the head of innovation. We had somebody there from strategy and planning who was then going to take responsibility for the finance side of it. We had deputy medical director there as providing that medical leadership. And we would discuss each MedTech, and we would all take away actions to then work to adopt and implement, but we'd all brought our own expertise to that table. So I suppose it is about just thinking about your process and the model for supporting this suite of medtechs within your own local organisation. And I know at the NQI Can Open meeting in December, when we all spoke initially last December, and that is recorded, so I'll have a look in a minute and pop a link for you in the chat. We shared the Sheffield Teaching Hospitals process, the model, so that is out there and available if anybody hasn't got a process yet and wants to look at it. And it is achievable, because I know I've just moved organisations and I'm now setting up the process in my new organisation, which I think will be pretty similar to the model I've been used to previously. So it's about getting the right people around the table, so you're not doing it all on your own. The right people with the right expertise are feeding into each one that you're looking at, including your clinical experts as well. Okay, so Jan, you've popped in. You're going to pledge to continue to build on and learn from the work we're currently doing on the adoption of some of the applicable products, which is brilliant. Just going to scoot back up. They're all coming in now and I can't keep up with what's coming in. So I think, Catherine, you've put the key element is the golden thread between research, innovation, improvement and audit. Yeah, thinking further about the partner teams within our trust, how we interact and overlap. Can't urge you to consider that enough, really. Stuart, you're taking it, you've pledging to take something away. Consider how we continue to reinforce good project management, explore those clinical audit principles. Fantastic. And then Derek, importance of aligned in the MedTech implementation with your national priorities, your local improvement programs. Absolutely. Yeah, oversight group, Sophie. Yeah, I would definitely recommend that. Yeah, as I said, be that voice on somebody's shoulder when you're exploring an issue within your organisation, and be constantly recommending the medtechs as a potential solution. Joining NQI Can, fantastic.
Got some great pledges, Vicky.
Yeah, they're really good, aren't they?
Mm.
Yeah, and definitely linking in with other processes that currently exist and learning from each other as well. I know within our regional networks, a lot of us talk about NICE within our regional meetings, and we're sharing and learning together. And I think the medtechs will become a standard agenda item on that meeting, really, to make sure that we are all supporting each other back in our own organisations. Oh, that's a good one, Carol. Pleasure to consider how learning from today can influence the draft AHSN spread and adoption canvas. Brilliant. I think with my NQI Can hat on, I think it's we're obviously pledging. We've got two more workshops coming up, but it is, I think, about working with our regional network chairs to make sure that we are supporting those local discussions within regions, so that you're all supporting each other as well. That's good. Keep them coming. Keep your pledges coming, because obviously we'll type all these up and share these after today. And I think we want to make those resources available for you. So we talked about putting that full set of criteria standards up with the slide pack and the recording as well. So if we think of any more links or any more resources that we can share as part of this workshop, we'll do that, so it's all in one place for you as well. Brilliant.
Fabulous.
Just to double check, those pledges will be anonymous in the sense that they will just come through as the pledge rather than associated with X person from an organisation.
Yeah, Jan's gonna, Jan said further reading from the links provided here today to give us the foundation to build on and embed innovation in our hospital. Brilliant. But yeah, I'll definitely be linking in now with your innovation leads, and obviously the AHSN under its new name, to make sure that you are helping or utilising their support that they're offering to help move this whole agenda forward within your own organisation.
Yeah, definitely like to echo that point, Vicky. If you know, if for whatever reason you're not fully linked up with your local AHSN Health Innovation Network, I'll pop my email address in the chat actually at some point.
Yeah.
If you want a connection made, then I'm happy to help to broker that. And yeah, I agree with you as well, Vicky. Some amazing pledges actually that have been posted from attendees. So thanks to you all for those. I guess that gives us an indication that the content that you've sort of seen and heard has been useful and thought-provoking, which is great. We're going to move to a very short Q&A now. We don't have a huge amount of time. I think we've got about 5 minutes. I do want to just reflect on a question that Alexandra posted actually around Gammacore timelines, because that feels worth reflecting on. Adam, I think I mentioned that you were going to talk to that. Do you want to offer a few sort of initial insights I can probably build?
Yeah, I've just put a lengthy note on Stuart, so we're typing after coming out of the thinking room. It's yeah. So as H said, we're commissioned over a 2-year period to kind of actively deliver and support systems to adopt these medtech innovations. So within that, within our ICBs and our providers within that, we support them. So I see each individual trust that's going to adopt as a project in itself, and then we kind of we then have to be really flexible. We've had a very unique year of strike action, which has massively impact when we can engage, opportunity to engage and actually get together and progress this stuff. So we've seen those impacts, but obviously what's required to support the providers to adopt, we just have to keep focused with that. And I think one thing that you know, I'm not just talking about myself, I'm talking about the other AHSNs. We have to be flexible. I mean, I think project managers do. I think it's a great asset as a project manager that needs to be there. You have to be flexible and adapt to change all the time. And I think we really need to be understanding of what providers are going through, what the teams are going through. So it's kind of working around them, and you know, we try and take as much on as we can to support them in what they're doing. But yeah, it's just that I've had meetings cancelled with one individual trust since start at summer right up until recently when they've been able to meet, and we keep that end timeline firmly in mind. We've got that, you know, we're in of the 7, if you read up on the policy, and the 7 innovations we're delivering on in this period up until end of financial year. I'm kind of using that to now go to providers, say we're actually on borrowed time now. We need to, you know, if there is an interest, we need to like kind of revisit this and crack on. But yeah, I just try and offer as much support as possible. From, as I was saying before, we help support draft and develop business cases. I'm doing quite a few of them at the moment. There's a bit of a backlog, but we do what we can to do it, just to try and keep it on track and keep it moving. But I think it's being flexible and understanding. So there's no there's no like it takes 3 months for, you know, like from someone showing an interest through to adoption. It can vary, unfortunately. So
no, definitely echo that, Adam. It is varied. Sarah, did you want to come in on this?
Just really quickly, building on what Adam said, it's understanding, as you said, the context, you know, strikes, etc., and that flexible approach, as Joe Murray had said as well in the chat. But actually looking at, you know, it's this thing of we've got to crack on. Yes, there is a mandate, but actually it's understanding the context why something isn't being implemented. So updates for the innovation department, for the partner organisations, for the AHSN to say, we are looking at this, we are reviewing our processes, we are in the queue with informatics to get hardware installed, to understand rather than it's just silence. And it's so much easier to communicate well together. So it's thinking about those wider links so that we can understand where folk are.
Yeah, you've just invoked another thought as well, Sarah, which you're really good at. So like a lot of what we've found as well, we've got an actual example around Gammacore as well with one of our trustees. Often with this, it's not just adopting a medtech. It often brings transformation pathway changes. It can have a knock-on effect. What we see now as the formation of the ICBs is there's regional pathways that are being agreed, and it takes time. It's the bigger changes, the GIRF push for creating urology area networks, so patients are treated over a collaboration of trust, so they get better service, they're seen quicker. They trust specialize in certain treatments, so you're getting the best treatment. These are big changes, and we kind of come along and we have to kind of adapt to that and actually see what those impacts those big changes will have. And the tech being in a provider or something is part of that, but it's quite sizable. And again, so we've had to, with the urology stuff especially, we've had to kind of align with GIRF, be switched on as to what's happening around that landscape, and knowing that adoption will come. But that's all around where the tech is positioned. So it's everyone every med tech that's on here is falls within a different medical specialism, and it brings different challenges to the environment and the landscape that we're working on. But it's great. It's very varied.
Well, I think, Adam, you hit upon an important point there. Although these are individual technologies, it's where they sit in the broader pathway, and then the pathway improvement work that needs to happen to make them land well and sustainably, that is key, like really important point. So yeah, thank you, Adam and Sarah, for those contributions. Just want to quickly reflect on another question that Alexandra's posted around shared learning, actually. Alexandra, we do within the network, we have a fortnightly learning session where we all come together. We bring together all the MedTech Funding Mandate leads from around England to just talk about what they're doing, how they're doing it. So make sure that I'll make sure that you're invited to those as you're new, and that you can come and listen to those conversations as well. Any other questions before we move on? Go on, Sarah, go for it.
Sorry, me again. So thinking about placental growth factor, when we're looking at the medtechs, we're looking at case studies. So for the Dorset Innovation Hub, again, look at our website. I'm under Sandra, if you don't mind popping it in the chat for the case studies. But looking at the learning and seeing if it's shared, there's also the NHS England reports. So looking at implementation, so that's helpful. And also, and something we're trying to push, is thinking about that benefit realization bit. So utilizing the NICE impact templates and actually translating that into your individual area.
Tremendous. Thanks, Sarah. Some more great resources there that we can share with people. Really good. Right. Thank you all very much for attending, for inputting, for contributing to those facilitated discussions, for listening to us as well. We want to do a quick evaluation with you now. Annie, I think you're going to hopefully pop this in the chat. Vicky, whilst that's happening, did you want to come back in as well?
Yes, I just had another thought about using technologies to really future-proof health and care. For those that aren't familiar with HCAP and NQICAM, we run a national clinical audit event, Clinical Audit Awareness Week, usually about June each year, and we run Clinical Audit Hero Awards. And I've just had a thought that if anybody does adopt and implement and start measuring through clinical audit, it'd be fantastic to have a few submissions to that category around where we've measured the adoption of some of the med techs in terms of really future-proofing health and care and making that difference around sustainability. I just thought I'd plug that because it'd be really good to see some submitted.
Tremendous. No, thanks, Vicky. You will also note in front of you, hopefully, that we've got our poll happening. We just want to grab some rapid feedback from you, please. Yeah, have a look at these questions. It will influence what we do for subsequent workshops. So I appreciate you just taking a little bit of time to just complete these questions as they appear.
I think we've got some hand raised. Stuart, Hannah. Hannah, do you want to come in with a comment?
Yeah, I was just going to ask about the clinical audit. So if you wanted to do a clinical audit, where would you get the funding to do that? And is there any, I know with MedTech Funding Mandate, we just record adoption and then we don't necessarily record anything beyond that. So I was just wondering whether there's scope to sort of build that piece in after we've got that, or if that's something you're thinking about.
I can talk to the second part of that question actually, Hannah. For the MedTech Funding Mandate, we do have a very simplistic measure in the network of success, which is all built around, is an organisation adopting it or not? We do want to strengthen the data side of the work that we do, and that might be where clinical audit can play a bit more of a role. For example, what impact has the technology had on the pathway and patients over time, would be something that we're actually starting to do a little bit of preliminary thinking about now. Vicky can probably come in and talk a little bit more about resourcing clinical audit.
Yes, I think it's contacting your clinical audit, clinical effectiveness department in your own organisation, because they will have a programme of work. So it's just making sure that you're registering it as an audit. But like we say, you need to consider that at the start of the adoption, really, so that you're factoring in and identifying what data and metrics you're going to pull on to be able to measure. So definitely go and knock on their door. They should know about these. Should know about the medtechs. Train of thought. I was just thinking about across the system and pathway, because obviously if you do refer patients on to another partner organisation or a tertiary centre because you don't offer that service, that procedure, etc., it's about trying to think about linking into some kind of measurement with those organisations, so that actually you referring your patients in to them being able to access this technology and measure their outcomes, that you're doing together as a joined up piece of work, because you as an organisation want to know that your patients have got improved outcomes, don't you? You want to know that the fact that you perhaps don't offer that procedure or service, that your patients can have equitable access to something that's not too far to go to, and it is actually improving their outcomes. And it might be that you consider changing so that you do offer that procedure in the future, especially if patients aren't accessing it because they've got to travel 17 miles down the road, say, to the other organisation that is. So definitely go and talk to your clinical audit, clinical effectiveness teams.
Thank you, Vicky. Sarah, did you want to come in?
Just a quick one, thinking about how we could communicate with folk that have been here today with resources and letting them know about the next workshop. So I don't know with information governance whether we can just take email addresses of people that had signed up, if we're okay for that. If not, can people put their email address quickly in the chat, and we will add you to the circulation of email to give links to the appropriate documents, but also let you know about workshop 2. But perhaps we could start sort of a discussion if people have got further queries for Vicky, myself, AHSN folk, etc. We can start a bit of a discussion.
I think that's a great idea, actually, Sarah. Thank you. If people could all just pop your email address in the chat. I think I've noted a couple of people who left as well. So that would give us a safe, a backup, really.
Yeah.
Thank you. Great idea. Any more questions or thoughts from people? If not, I will quickly mention our next workshop, which we don't have a date for yet. It will be after the winter, conscious that colleagues, especially in the system, are going to be busy for the next few months. So we want to position this probably in the springtime. You'll hear a bit more from us in due course. In terms of its working title, we're thinking of something around cultural and behavioural insights, and some of that sort of human behaviour stuff that we know can either make things happen very quickly or get in the way of adoption of innovation. So it will be more on that, really, and we'll think about how we weave in some of our learning from the network into that session, as well as thoughts from Vicky, Sarah and other colleagues as well about their experiences. So hopefully you can all join us for that. Hopefully you found this useful today as well. Huge thanks to Sarah, to Vicky, to Adam and to Joe for driving the content, for doing a lot of work in the build up to this, for developing such a great session. And look forward to seeing you all in the spring, hopefully, after the winter. good luck over the winter if we don't see you,
Yeah.
and see you then.
Thank you.
Thanks for joining us.
Yeah, thanks so much, everyone.